Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is brought to you by AACN's online nursing community forums, offering support, inspiration, and sharing of best practices online, with information available at www.aacn.org/AACN communities. Now, here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to the Voices in Nursing podcast. This is Dr. Vicki Good, AACN's Chief Clinical Officer, and I'm joined by my colleague, Andrea Schmidt, one of AACN's Clinical Practice Specialists.
Hi, this is Andrea. Welcome to today's episode.
Andrea, I think every nurse has at least a few years of experience, develops what they call a spidey sense, or I always called it a feeling in their gut about patients. You know that moment when you look at your patient, you say to yourself, they don't look right, and 99% of the time, the nurse is right. Nurses bring this incredible value to healthcare, but how do you measure this value that the nurse brings?
I agree with you, Vicki. I really believe that nurses do have that intuition that there's something wrong with their patient. And today's guest took that question on, and it has had significant success. She developed AI software that captures and quantifies the behaviors a nurse demonstrates before a patient begins to deteriorate. But before we get any further, let's have our guest, Dr. Sarah Rossetti, introduce herself. Sarah, would you tell us a little bit about yourself and your nursing career?
Yes, and thank you so much for having me here. So I'm Sarah Rossetti. I'm an associate professor in the Department of Biomedical Informatics at Columbia University, and I also have a joint appointment in the School of Nursing. So by background, I'm a critical care nurse. So I've worked in several different intensive care units and several different hospitals. And then I've been conducting clinical informatics research for over 15 years now. I have my PhD in nursing and postdoctoral research training in biomedical informatics.
So let's start learning about your research. It is absolutely fascinating. And your study was funded by NINR, and it was called the Concern Study, or Communicating Narrative Concerns Entered by RN's Early Warning System. That's a mouthful.
Yeah.
I see why you called it the Concern Study. So will you describe the primary aim and the overview of your research and how it differs from other patient deterioration index scores, such as the Modified Early Warning System, or what most of us know as is the MUSE system?
Yeah, absolutely. So we intended to, and we were successful in creating a measure of nurses' concern. And as you mentioned earlier, nurses have this sense of when a patient is not doing well. And it's not a sense that is not based in anything. It's expertise is what it is. And so it's based in data, and it's based in the nursing observations of changes in a patient's state. It's just that these changes are subtle. And so other early warning systems use vital signs or other laboratory measures, which actually are late indicators of patient deterioration. And so what nurses do day in and day out at hospitals throughout the country is they identify early indicators of patient deterioration, ones that our physiological markers, our vital signs in our labs can't yet identify. And when nurses start to identify these, they change their behavior. They monitor the patient more. They're going into the patient's room more frequently. They're assessing the patient more often, and they're doing some additional interventions and actions and communicating to the care team more often. Those behaviors, they record in the electronic health record. And because of that, we're able to process that data in an AI model, an artificial intelligence-based model, to identify early on, 2 days earlier than other early warning scores, when patients are at risk for deterioration. And so nurses really put together these subtle signs. They start to increase their what's called nursing surveillance of the patient. And when these patterns come together in a certain way that our AI model has detected, we then flag that these patients are at increased risk. And this is now a data point available to the entire care team so that they can have discussions and be on the same page about this patient's level of risk.
That's fascinating. I would love to be able to sit here and talk for an hour about just that topic alone. But these specific patterns that the nurses recognize, are there specific ones that are coming up more often than you're able to teach the AI model?
Absolutely. One of the most clear patterns is increased vital signs being measured by a nurse. And one of the reasons that this is so clear is that nurses have very specific minimum standards in which they need to measure a patient's vital signs. Depending on if the patient is an ICU patient, it's typically every hour. If they're a patient on a regular floor in the hospital, it may be every 4 to 6 hours. So we can actually see when the nurse then increases their frequency of that monitoring. If in the ICU, they start monitoring every half an hour or even more frequently, or on the acute care floor, they're monitoring the patient's vital signs. All of a sudden, there's these extra sets of vital signs every 2 hours. That's a really strong indicator, because let's not forget, nurses are very busy and nurses already have a lot of information to document in the EHR. So just the fact that they're going above and beyond to take this extra set of vital signs and then record it in the EHR is a very strong signal that this is a clinically valuable and an important data point. Interestingly, in our model, the value of the vital sign is not what is driving the prediction. It's the fact that the nurse took the vital sign. And I like to use the example of, for a patient on a hospital floor who should be sleeping through the night, because nurses know that that's important and patient sleep is what helps them recover. If the nurse goes in at 3 a.m. to take a set of vital signs, that's a really strong signal. Taking a set of vital signs at 9 a.m. for any hospital patient is not going to be a strong signal, because that's a very common time in which vital signs are taken. Mm-hmm. There are other features in the model too. When a nurse doesn't administer a medication that's scheduled for that patient, that can be a signal, because the nurse assesses that the patient's state is more unstable and perhaps their body can't tolerate that medication. For example, a medication that's intended to bring their heart rate or their blood pressure down for somebody that has high blood pressure. But at this point, for some reason, that patient's not at their baseline. They're lower. And so it wouldn't be a safe administration, and it's better to talk to the team about what should happen for that patient. So these are behaviors that are doing something different for the patient or at a different time, that indicate the nurse is seeing something that needs to be followed up on and is changing the course of care in a way that's responsive to the patient condition.
Sarah, I wanted to follow up on something that you said. I found it fascinating, how it's looking for prediction, right, of standardized times for vitals or medications, withholding a medication. But does it have a way to take into account, let's say the increase of vital signs frequency is increased because they're post-procedure?
Yes.
Or they've received, sedation for a TEE or something at the bedside, or maybe they held it because they were going to off the unit for a procedure. How does that work?
Yeah. Great question. So it is an advanced AI model. And so we actually, it uses this approach called ensemble-based modeling, which means there are many different models for particular kind of contexts, as we call it. So we have about 1,200 models. Some of them apply to ICU patients only, some to acute care patients. But essentially, it's that there's a particular model that fits that patient's characteristics, as you're explaining, whether they're post-procedure or some other kind of care process that's going on. So, for example, the model will know what hospital day it is for a patient, because there are certain patterns of care on hospital day 1 that are different than hospital day 2, that are different than hospital day 3. Same with night shift versus day shift. And actually, seasons are incorporated into the models too. You see different patterns in the winter versus the summer. And so all of these come together and combine in order to then identify which of the 1,200 models is picked. And then that model is the one that runs all of the patient's data and the frequencies and the types of documentation that nurses have entered into the EHR to process to identify whether that patient's at risk or not.
Wow, this is incredible. And I think there's so many people that are, I would classify as afraid of AI, but what an incredibly valuable tool this is. And some of the things that you're talking about make good common sense, but it's something that we can't see in a pattern, but AI can see it for us. The part that was just incredibly interesting to me is you also talk about unstructured data sources, like calling the doctor or, certain orders like an EKG being obtained, versus the structured things like the vital signs. So talk to us a little bit about the importance of those unstructured data sources that you've identified.
Absolutely. We do process nurses' notes as well for certain mentions of information that indicate they're concerned about the patient, such as MD notified is absolutely one of those phrases. Interestingly, the narrative notes, they contribute to the model, but the structured data is actually what drives the strongest signals in our model. Our electronic health records have evolved over many years, and nursing
Right.
documentation is highly structured. And so we can identify these patterns from what we call the metadata of their documentation. So the presence of the documentation is a signal. If the nurse writes more notes, we actually can use the metadata of the fact that they wrote a note or the fact that they wrote an event note as part of our signals in the model too. So it's not only the content of the note, but the presence of a note. Nurses also use what's called comments, and those are associated to vital signs or other structured fields such as medication administration. And the presence of a comment, this is that the action is recorded by right-clicking on that structured field, and then you write something that's about the length of a text message.
Right.
It takes a little bit of work, right? We know nurses are busy. They're putting the time in to write this comment. The presence of it says a lot. And usually it is that the nurse is trying to highlight a structured value and to clarify what's going on there. That's a really strong signal. For example, a patient's oxygen saturation may look normal throughout the shift. All the actual values are normal. They're 95 and above. But the nurse has been increasing the supplemental oxygen for that patient over the course of the shift. And these are two structured data points that are in two different places in the flow sheets within the EHR. And the nurse is taking the time to link those concepts to make it clear to anyone who then goes in to read the EHR to say, well, yes, they're still satting at 95%, but they were at 2 liters nasal cannula when I came on the shift, and now they're approaching 6 liters. And so we need to start considering, what other escalation of care might be needed.
So from what you're describing then, because I always worry about charting by exception. I was raised as a nurse a few years ago, we'll just say that. And, we always documented every single thing that happened. So the charting by exception makes me a little nervous. But what you're saying is it probably doesn't impact this model much because that's more of unstructured communication if we're not doing the narrative as often.
Agreed. We have looked at data during interesting times, such as the COVID pandemic. We still see these strong signals from nursing documentation. I actually, in the other half of my time, researched the problem of documentation burden. So we need to decrease the amount of documentation that we impose on nurses that they have to record. What's so fascinating is in all of that research through qualitative and quantitative methods that we use, we keep finding that nurses identify what they call essential documentation This is information that they see as important to drive decision-making among the care team, communication among the care team, and coordination. And they take efforts to document that in near real time. It's other documentation that are documentation requirements that the nurses, that may be there for secondary uses that the nurses may document in batch or later on, but those are not driving care decisions. So what we're really modeling in concern is the information that the nurses value as important to drive their decision-making and their communication coordination with the team. And so it is present and it surfaces in the record when we look at these patterns.
So, many seasoned nurses, because we were trained to document everything. I'm kind of piggybacking on what Vicki is saying here. You right click when you're going to give your supplemental potassium, and you write and you put the documentation of the potassium was, 3.2 or whatever. So obviously it's not a problem. It's part of your actual protocol and you're doing what you're supposed to be doing. Does it in any way take into account some of that over documentation when it's not really meaningful?
Yeah,
Because you could really pull that
question.
right out of the labs, but we feel this need to just document it,
Yeah, that's a great question. And so the answer is yes. So because it's an AI-based model, if it observes that overall nurses always put this comment in associated with, administering potassium, and as we were training the model, that was never indicative of, a bad outcome, then that wouldn't be a signal. But if then this was something that was less common, and then in these big data sets was associated with some bad outcomes that we're trying to predict, then it would rise up as a signal in the data. So, AI really gives us the opportunity for it to be data driven. And with that said, the modeling was done by a team of nurse experts and data scientists, some of whom are nurses and data scientists. And so there is absolutely nursing expertise in what's called the feature engineering and some of the ways in which we identified features or types of data to look at to see if the patterns were there.
That's amazing. I love this.
Yeah,
So
I know. It's crazy.
it is. It really is. So once the model analyzes, what happens then next? And how is the healthcare team made aware of the information?
Yeah, great question. So I'll remind again, half of my research is on decreasing documentation burden. So we certainly were not going to be building a model that then over alerted and alerted at the wrong time and place and alerted the wrong person, about this risk. So much of the work was on what we call user-centered design with both nurses and physicians and nurse practitioners and physician assistants, so the core team members in the hospital setting, around not just where would you like this to be displayed, because that was certainly part of it, but how would you like it to be displayed, as well as how would you even want to be prioritizing patients. So we started actually, when you have an AI or predictive model, it just computes, it's just a calculation, right? That's computed. So we had to take the work to get the output of the model into something that was understandable and meaningful to clinicians. We pretty quickly landed on a 3-point score, and what's displayed as red, yellow, or green, what your level of risk is. Working with clinicians, with nurses and other members of the care team, we quickly honed in on the fact that the red patients are ones that care team's probably already going to be aware of. So we identified that about 2% of the population of what we compute should be red. It would not be meaningful to nurses or physicians to have half of your patients red. Because how does that help guide care? We're trying to guide care and prioritization. So then about 20% of the patients are yellow, because that's what to focus on, and ends up being a manageable number, and the rest are green. So just the process of what the thresholds are for patients landing into the score categories is a process, and that takes some data science as well, didn't want patients to bounce around. Oh, now they go from green to yellow, and then now they're back to green, and all of a sudden they're red, and now they're back to yellow. That's meaningless as well, because it's confusing. And then you don't trust the score. So a lot of time was spent working with clinicians so that they trust the score, so that they understand the score, so that it's displayed in a way that's meaningful to them, and then displayed in a place where they'll see it, but it won't be burdensome. So it displays in what's called the patient list. And so this is something they see upon login to the electronic health record. There aren't pop-ups, it's not something that you have to click away from, but it's something that you can see very frequently every time you log in, and it's there, and you can get comfortable with how it's displayed. I'll just wrap up with, we also do provide, though, more details. And so a clinician can double click on the regular green icon to then show, well, what were the actual reasons that this score was generated for this patient? Why is this patient yellow? And we then actually pull in data from the EHR that shows, that was driving the calculation. And we also show some graphs where it shows the patient's score over the past up to 72 hours, how that trended, and where the patient is relative to other patients on the unit. The nurse or physician doesn't need to log into this detailed screen every time or pull it up every time, but it's there for them to be aware of and pull it up, when it makes sense to them. But they're busy. And so just the regular green can be enough information.
Well, I'm sure that provides a great source of education to them as well, especially some of our newer nurses that are struggling with how do they synthesize all this information that's coming at them. This tool, if I understand your research correctly, is identifying deterioration basically 2 days earlier than, some of the other methods. So what have been some of the patient outcomes from utilizing this tool?
Yeah. So we conducted a multi-site cluster randomized controlled trial. And that's something that is relatively rare for AI-based interventions. It can be hard to do that in the clinical setting. And we were thrilled that we observed a decreased risk of mortality, decreased risk of death by just over 35%. For our patient populations across both sites. Also, a decreased risk of sepsis of 7.5% in just over half a day shorter length of stay. And interestingly, an increased transfer, about 24% more likelihood of transfer to the ICU. And so that increased ICU transfer relates to what you're saying about this score is identifying risk 2 days earlier, because our sub-analyses of the results of our clinical trial show that these are early transfers to the ICU, which then allows the care team to intervene. You're intervening earlier. It's a more controlled environment. You have a better likelihood of a good outcome, as opposed to a transfer to the ICU when the patient's already deteriorating and there's not much that can be done to save them. And so that early ICU transfer, is really critical to intervening on outcomes for deterioration risk. Other early warning systems, many have been implemented at hospitals throughout the country, but the clinical outcomes observed are typically haven't been as strong. And we think it's because they're more late indicators of deterioration. And the care team simply there's not as much that they can do when it's a later identification.
Yeah, I mean, this is a much more proactive model than reactive, which is typically when Muse goes off, the patient's already in trouble.
Yeah. Now, how does it compare with documentation? So a lot of the systems are driven by when you document, right? And so if you're documenting 3 hours later, there's a lag time there. Does this have that similar impact, or is it just looking at things on a global scale that some of that's just a small piece of it where it doesn't matter so much?
Great question. Certainly, we know that some documentation ends up being delayed. But because it is an AI-based model that has used large data sets for its training and validation, those patterns are accounted for in the model. But I'll also say that what we've really seen is that it appears that nurses consistently will prioritize documenting the information that they see is important to reflect changes in the patient condition and information that is important to communicate with the care team. And those really are the data that are feature driving in data in our model. Even during the COVID pandemic, I mentioned before, we observed these signals kind of still held, right? This was a time when nurses and all clinicians were under major stress and burden. And actually, it was also a time when, at a lot of hospitals, the requirements for documentation were much less. Yet we still saw, and actually in New York State, the requirement was just that they needed to document medications. So it was such a stressful time for clinicians that we said, you don't have documentation requirements anymore, except you do have to record what medications, because that's a big safety issue. We still observed the same signal in our data. Nurses were still entering this information that they found valuable as a driver for decision making, which was, really phenomenal, given what was happening during COVID.
Well, when you mention it that way, it makes me think when you're caring for, depending on where you're working, 2 patients or 5 patients, who do you tend to document the most on? The one you're most concerned about. So that actually makes total sense. And I like the fact that it helps push the trends of what's going on forward, because I think in healthcare, we often don't go back in time and look to see what's happened because we don't have the time. So I really like this. And I hope that the staff who are using this are getting a sense of either security or validation in what they're feeling.
Yeah, absolutely. And I'll just add that I think as we talk to nurses, they pretty quickly understand how this algorithm works, why it works, because it's based on how they practice. It's based on how they document. Non-nurses may not understand it as quickly because it is kind of an invisible type of nursing care, nursing surveillance, that non-nurses might not realize. The nurse is not just going into the patient's room to help them with their lunch and open up containers on their tray. At the time that they're doing that, they're reassessing the patient and they're observing many different clinical indicators that they're in a targeted way looking for, and then maybe recording them after. And so it's something that previously I do feel is invisible nursing surveillance that we have been able to quantify.
So Sarah, one thing that was fascinating is you've partnered with the American Nurses Association to develop a toolkit for other facilities to operationalize this program or initiative. Could you tell us about the toolkit and how our listeners can potentially access it?
Absolutely. Yes, so American Nurses Foundation Reimagining Nursing Initiative has been an incredible partner. The toolkit is live under concerntoolkit.org. And it provides all of the resources that are needed to implement concern at a hospital. So everything from the slide deck that you would take to talk to your senior nurse executives to pitch the idea and say, we think we should implement this, to the resources that you use to train nurses and physicians and NPs and PAs who will actually be users of it. And those resources are all posted there. Individuals from different hospitals can create an account and register and log in and access them. And then on a case-by-case basis for the sites that are really motivated for this to actually implement, we can enter into an academic research license to do that work.
Wow. I'm just incredibly grateful that you're willing to share your work in that manner with so many that can benefit many, many nurses and many, many patients. So thank you for doing that.
Well, thank you. And as a nurse, given the outcomes we've seen, my motivation is for it to be in every hospital. And I think that it's also based on expert nursing care. And so I think to acknowledge our nurses out there that are able to do that work, and that's why it works. And I think that we have an opportunity to kind of reflect the great work that they do in using this model.
I so love the fact that this is nurse-driven research. And, it's just so impressive. It really is. And I hope that this makes our listeners, see all that can be done, if you have a desire for nursing research and where you might be able to take an idea. And I just think it's great. And so that being said, you've been a part of the AACN family for many years. And one fun fact is that AACN actually helped you with your early research. So what role did AACN play in that?
Yes, an amazing role. So when I first started my postdoctoral research fellowship, so I had just graduated with my PhD in nursing, and I was now had this opportunity to submit for my very first grant, and I submitted to an AACN grant and received it. And the grant was for concern, and it was to explore if these associations were present in the EHR data. The ones that I hypothesized were there based on my clinical experience, and partnered with Ken Ricato, who was also at Columbia at the time, and he was finishing his PhD. He's a nurse scientist as well. And Dave Albers, who is very computational and a physicist by training and a biomedical informatics researcher. And we got our initial data sets. With that, it was just $10,000, and that's what we needed. And we got started, and we had our first publication that showed that when nurses document comments in their flow sheets and certain increased vital signs, it is associated with patient mortality. And interestingly, in the ICU, it's actually associated with decreased mortality and cardiac arrest, but in the acute care floor, it's associated with increased. We really saw this. Well, this is an indicator of something different going on, perhaps more delayed communication, more challenges and barriers to the team kind of getting on the same page. And it absolutely was foundational to the outcomes that we have in the trial. So we then had that preliminary data, and we were able to submit for a grant from NIH. And it took 3 times, but we did receive that funding from National Institute of Nursing Research. And we were funded by them for the past 8 years. We had just started our 9th year of funding. Unfortunately, it was recently canceled, that grant, as part of the cancellation of many NIH grants right now. The AACN funding was essential. I had been trained on a training grant by the National Institute of Nursing Research, then received this R01 grant that allowed us to do the multi-site clinical trial. So funding for nursing research is absolutely essential. And unfortunately, it's under threat right now in terms of NIH funding. So I think that that's something that we need to be discussing, because we need to be training our nurse scientists. And there are young nurse scientists who have, even better ideas and a lot of things that we can do. And so I want to emphasize that we need that funding to allow them to do that.
And I'm grateful that AACN could play that role. And
Absolutely.
The old saying, you plant a seed and then you watch it grow. And clearly, just by having that grant, we planted that seed, and it's grown into this amazing body of research. And I just want to remind our listeners that we still do those grants. And so you can find that on our website at aacn.org under our Nursing Excellence section. And so we're constantly looking at ways that we can partner with budding nurse scientists, we'll call it, and being able to support that. I just Sarah, this has been fascinating, and I am so grateful for your research and for all the ways that you've impacted, not only the nursing profession, but our patients. So thank you for your life's work on this and sharing your expertise and your passion with us today. It's been truly amazing.
Well, thank you for having me. It is quite an honor to be on an AACN podcast. So thank you.
No, we're delighted that you took the time. So thank you very much. And to our listeners, we want to thank you for joining us. And we would love to hear your feedback on this episode and any ideas that you might have for future episodes at podcast@aacn.org.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's online nursing community forums, offering support, inspiration, and sharing of best practices online with information available at www.aacn.org/AACN communities.